Good evening, everyone, and welcome to the Aurora Recovery Center webinar series. And tonight we are on our fourth webinar, and we're going to look at and explore the idea of opiates, opioids, and methamphetamine. My name is Ian Rabb, and I am the Director of Business Development and Public Relations Officer at Aurora, as well as an addiction specialist. And we're here to do this series for two reasons. One reason is to educate the public on different drugs and the effects of those drugs and access to treatment, and also to educate those that might be afflicted. And hopefully some of you are tuned in and can join in the discussion with us. Just a reminder, please start getting questions in. You're able to send questions to us. This is an interactive webinar, and we appreciate that. And so please get your questions into us in a timely and quick manner. We're really happy that you made it here. So tonight we're going to be talking about opioids and methamphetamine, and Jerry Verrier is with us. With his own story of recovery from an opiate addiction in the 80s, Jerry has worked in the addictions treatment industry for at least the past 30 years with youth, adults, and families. Jerry brings a wealth of experience steeped in trauma-informed best care practices. He's graduated from the University of Manitoba with a certificate in applied counseling in 2003, and from the University of Winnipeg with a degree in human resource management in 2006. Welcome, Jerry. Jerry specializes in motivational interviewing and applied counseling, combined with a deep passion for the success of addicts in recovery, probably because of your own success, as we know that most of us that have recovered want to share the message of hope with other people.
Absolutely, and I'm excited. I've been doing this work for a long time. A lot of it has to do with my own recovery, but it's good work, and I like doing the work because when I was 15 years old and struggling with addiction and a ruined family life, I had to make a decision about leaving home, and I found myself out there alone. Little support, little assistance, and little understanding, and so I finished a 15-year bender in recovery. Got a lot of help from peers, and it's interesting that it was peers and not so much professionals, but other addicts in recovery. And it made a huge difference in my life. I was able to eventually move away from using any kind of addictive substance, and in a haphazard kind of fashion, found myself working in the industry with teenage boys originally. It hit home for me.
What I find really interesting about both our stories, 30 years ago you were addicted to opiates, and it's only in the last 2 years or 5 years that there's really been this magnifying glass on the use of opiates in society. And for me too, I used opiates and methamphetamine, and that was 16 and a half years ago when I quit, and I started way before that. Yeah. And we only hear about these, we only are really hearing about these things on a regular basis now in 2017.
Yeah, unfortunately, and you're right, Ian, we're only paying attention to the tragedy of opioid addiction. And I was just talking to a friend of mine about this today, that over the 30 years, I've lost approximately 65 friends to opioid overdose.
Yeah.
So it's a scary reality, and it's not new. The attention to it is new. And I'm glad that finally the attention is being given to the issue, because it is a serious issue, and it's destroying our communities.
September, October of this year, in just 8 weeks, I lost 12 people that I was working with closely to opiate addiction. Yeah. So I understand the pain and loss for families, and the turmoil that people are in, really trying to get their family members help, especially on the opiate side, and methamphetamine as it resurfaces now again, and the deep psychosis and crime connected to methamphetamine is really troublesome, and youth using it way younger and going right to injectables. In both cases, we're finding that the youth are going right to the injectable form of any of these drugs at 17, 18, 19, 20 years old, where in the past they would use it other ways and ultimately graduate to needles.
What we're seeing in the industry right now is a surge in young women who are getting into crystal meth and directly into injecting it. And so the impact is much more significant in that fashion. The psychosis is much more significant. And it seems like the people who are abusing crystal meth and opioids are getting to be younger and younger and younger.
And treatment times, really inpatient treatment times, need to be longer and longer and longer, really, to change the effect and change their lifestyles.
The truth is, every day a person stays in either in a treatment setting or in a relationship that is conducive to recovery, they will have that much more success.
Right.
And you don't undo years and years of brain trauma and trauma to family settings and relationships and to ourselves.
Right. So you have a little bit of a presentation for us. I want to give us some statistics and some facts, and we'll start that way. And again, please get your questions in through the website at AuroraRecoveryCenter.com, and we'll answer your questions as we move along. But first, I'm going to let Jerry give you some statistics and some facts around methamphetamine addiction and opiate use.
All right. So one thing I wanted to clarify before we begin is I've got tons of statistics, fact-based statistics, I might add, on the situation with opioids. And when I go to look for stats on the use of crystal meth and recovery stats and such, it's interesting that the stats with respect to crystal meth are pretty skimpy out there. And the stats that I do find are stats that are driven by crime statistics. And yet it's not the same situation with opioids and other substances. I've always found this interesting, and it's not new to me. The idea that the problems identified related to crystal meth seem to be coming out of the justice system, that there's this, and it's not like opioid addiction is not about crime. It very much is how people get their drugs, where the drugs are coming from in terms of mass quantities. It's all related to crime. And it's good that we can get healthy, good factual stats from the health systems, but it's disturbing that I can't get good stats on crystal meth from the health system.
It's interesting you say that, because actually my bottom was a potential 68-year prison term in the United States. And one of the things that I had to do was testify to the grand jury around about crystal meth, about the production of crystal meth and identity theft. And it was really around justice also. So I can see how, and there's a huge connection. And what they wanted to do in that grand jury was connect the two. They wanted to show how methamphetamine and identity theft were so connected. And nothing's changed today. We know that crime is driven by people on crystal meth.
Yeah.
In different ways than other drugs
that are not easily recognizable.
Correct.
Stimulants seem to get people going and seem to get people to act out in a very impulsive fashion. I've run out of meth. It's midnight. I need money. I'm going to get money.
Yeah. There's
opioids at that point.
You're asleep,
nodding off, dreaming, and all that good stuff that people believe come with the abuse of opioids. So,
and we're going to get the question later. So, just because you brought that up, it's very interesting. The crime statistics around cocaine or crack and crystal meth are very different, because with cocaine and crack, they run out and they go rob a domo.
Yep.
With crystal meth, it's usually inventive ways of identity theft or stealing money or doing things that are on a much grander scale than that of
absolutely. Absolutely. And just while we're on that note, the stats that I could find related to crystal meth are kind of like a roller coaster ride, that there seems to be a lot of fluctuation. And what people are not understanding is that it's gone from a product that is produced rurally in both Canada and the US to now the bulk of crystal meth is now coming out of Mexico. So the purity is better. It's not that it's more available, but it's also that it hasn't disappeared simply because we're not hearing about meth labs being busted anymore. They've just shifted. Organized crime is very good at supplying their market. They're very good at adapting.
It doesn't help that good crystal methamphetamine is 100% dissolvable in water, right, and just looks like water for all intents and purposes when it's mixed with water.
So something that's important to understand about methamphetamine or crystal meth is, first and foremost, there are performance enhancement issues with crystal meth. And in Southeast Asia, there are 16 million people who use crystal meth as a performance enhancer. And the reasoning is that they're poor, they have to feed their families, and end up needing to work 16, 18 hours a day.
Yeah, well, in Thailand, there was an epidemic around truck drivers.
Mm-hmm. And it's not just Thailand. I can vouch for the fact that in Canada there are truckers who are using both crystal meth and crack cocaine to improve their alertness, to stay awake, which on one hand is interesting, on the other hand it's frightening.
Yeah. Just one little interesting tidbit around the history of crystal meth. It was invented by the Japanese in World War One to keep their pilots and warfare awake. And ultimately, the research shows that even Hitler was injected 8 times a day with crystal meth. Makes you insane.
Yeah.
I can tell you that for sure.
Another thing to note is that it is illegal to acquire methamphetamine in Canada. In the U.S., it is sometimes, and I'm going to say almost rarely used to treat ADHD as well as narcolepsy. So in the U.S., there is some medicinal value to the drug, but it's nowhere near as common as people might think it is.
It's called dexedrine, and
dexedrine
is dexamethamphetamine. It's really the same chemical structure almost as crystal methamphetamine.
There is also in the with youngsters who are engaging in so there have been stories of the performance in terms of sexual activity.
Sexual appetite is out of control on meth. And
so that's another contributing factor. And what ends up happening is before the person starts dealing with psychosis, they're so far into it that the psychosis is significant and impairing and very difficult to get by. The other thing to note about crystal meth as opposed to other drugs is any chronic user will be looking at up to 2 years in terms of their brain healing and their ability to recover normal brain function.
The one thing you said crystal meth psychosis.
Right.
And one interesting fact about meth psychosis or amphetamine psychosis is if someone quits even for a week and quits for a week and then does it again, the psychosis is usually in fact worse.
Right.
Every single time.
Yep. Well, I mean, it also goes with the raising of tolerance levels.
Right.
So the more you use, the more tolerant you become. The more tolerant you become, the more you need. The more you need, the more brain damage you're actually doing, and the more significant psychosis. So it's a lose-lose situation with crystal meth.
It's very hard to get off of.
It's highly addictive, very difficult to get away from. And one of the reasons why it's so difficult to get away from, it's so easily available.
And cheap.
It's cheap. And so when people are struggling in recovery, they know in the back of their mind, their addicted brain is still telling them, yeah, that's what you want. Cheap and easy, cheap and easy, cheap and easy. Why are you going through this mess? This is way too difficult. All you need to do is pick up your phone, call your buddy, and you're going to get, it won't take long for you to get it, and then you're going to be happy again. Yeah. So and the addiction industry in this part of the world has not been dealing with crystal meth as long as, say, in southern U.S., in California, for example, they've been dealing with meth addicts for probably up to 30 years now. So we're still adjusting, we're still adapting, we're still trying to work with them, but it's certainly that initial period of living clean and with no drug replacement therapy available for people who abuse crystal meth. There's a significant struggle there. So we're working hard at keeping people in treatment. We're working hard at keeping them in the facilities.
You made a comment about just get a little bit and you'll be happy again. And I just, I think it's prudent to also talk about what changes in the brain chemistry of a methamphetamine addict. And the fact that your dopamine receptors think they're getting a lot when they're doing meth and they're not. Yep. And then when you stop, actually you have it's very difficult to get out of that depression. And there is no pleasure for a couple of years there at all. Your pleasure sensations are depleted and gone completely.
And that goes across multiple drugs as well in recovery. The brain damage takes a while for the brain to heal. It needs to be rewired. And people often perceive that to be about boredom, and it's not just about boredom. It's the fact that people can't enjoy the normal things that normal folk enjoy. Yeah. And so they really struggle with, well, this is flat, this is boring, this is not fun. I know how to have fun. I know where to get fun, and it's only a phone call away. And so it's a constant battle of keeping people in that mindset, keeping them motivated. Motivation is such a key part of recovery. It's what helps actually an addict rewire his brain, that the more that they can enjoy, the more they can anchor that experience and reflect on the goodness of that, the value of that. That helps the brain rewire to normal function, to normal pleasure, to experiencing things that I now enjoy. Holding a baby, going for coffee with a good friend, the things that don't require me to abuse a drug. Yeah. And of course I'm able to go to bed at night. I'm able to sleep. I feel good about myself. And hygiene. And I'm not chasing a dragon.
Yeah.
Right. So
let me hear some of your statistics you were going to
So
talk
as it
about.
applies to opioids, there's lots of stats out there. And I've got a bunch of sheets here, and I'm just going to run through some of the facts because I do think that they're relevant. So these are some stats from the American Society of Addiction Medicine in the year 2016. So to start off, I'll give a brief definition. So opioids are a class of drugs that include the illicit drug heroin as well as the illicit prescription pain relievers. And some of you may have heard about some of these, and some of these you may have never heard of. Oxycodone, hydrocodone, codeine, morphine, fentanyl, and others. Opioids are chemically related and interact with opioid receptors on nerve cells in the brain and nervous system to produce pleasurable effects and relieve pain. The pleasurable effects of drugs is what actually wires the brain for addiction. That's how our brains are wired. Anything pleasurable we attach to, we want more of it. We want to experience that again. Addiction is a primary chronic and relapsing brain disease characterized by an individual pathologically pursuing reward. Again, pursuing reward and or relief by substance use and other behaviors. And so when you're talking about opioids, it's a drug that essentially produces a dreamlike state. It allows a person to forget about what's happening in their world. Stress goes away. It blocks pain receptors, so you're not feeling any pain. And I'm going to suggest it also blocks emotional pain.
Well, it must, because if you become a regular user of it, you're not blocking physical pain. You're really blocking emotional pain, right?
It ends up becoming about emotional pain. Certainly when I was using, I was able to forget. I was able to sleep when I wanted to sleep. Enter this dream-like euphoric state, and life was just wonderful. Meanwhile, my life was going to the pot. That I was destroying my relationships with my family. I was destroying relationships with friends. Employers couldn't trust me. I was committing crime, and I'll be honest about that. I have no shame about my past. I've made amends for what I've done and who I've been, and I'm not shy of sharing that with people because it's the truth. And
crime goes hand in hand with drug addiction. Let's face it.
When you're using upwards of $800, $1,000, $1,200 worth of drugs in a day, that's not coming out of the bank.
Correct.
And I wasn't functional enough to hold down a full-time job, so the money had to come from somewhere.
Likewise.
So of the 20.5 million Americans 12 years of age or older that had a substance use disorder in 2015, 2 million had a substance use disorder involving prescription pain relievers. And 591,000 had a substance use disorder involving heroin. So that's just, one of those facts that pops up. This is an interesting fact. Drug overdose is the leading cause of accidental death in the U.S. with 52,404 lethal drug overdoses in 2015.
And we know that it's gone 4 times that in 2017.
So folks, keep that in mind. The leading cause of accidental death is drug overdoses.
I heard an interesting fact. It's like 1 airplane crashing a day.
Mm-hmm. Mm-hmm.
Think about that. What would we do in this world if 1 airplane crashed today? We would take action to figure out what's going on. Yep. And yet that many people are dying a day in the United States and Canada of overdose. And what actions are we taking?
And it's preventable. Treatment is treatable.
Yeah.
There are many recovery centers. There are many groups. There's lots of fellowship out there. There are lots of people like me and you who are waiting for people to come to the door and ask for help, because that's, I don't see myself doing anything different. This is the career I've chosen. It's a good meat and potato kind of work. And I really believe that I'm contributing to my community this way.
And seeing the transformation of people is one of the greatest gifts of all.
Yep, absolutely. So another stat. From 1999 to 2008, overdose death rates, sales, and substance use disorder treatment admissions related to prescription pain relievers increased in parallel. The overdose death rate in 2008 was nearly 4 times the 1999 rate. Sales of prescription pain relievers in 2010 were 4 times those in 1999.
Wow.
And the substance use disorder treatment admission rate in 2009 was 6 times. The 1999 rate. So people are looking for help. people are knocking on doors. People are desperate. I know I was,
One thing that's very different about methamphetamine and opiates, and we're talking about opiates now, is methamphetamine seldom causes death.
Right.
There's you hear very little about an overdose
Yep.
of methamphetamine.
Yep.
But yet opiates, it can be immediate. One mistake and you're gone.
Right. And in my opinion, it doesn't make one drug more dangerous than the other necessarily.
No question.
So
just fatality is fatality.
And here's something interesting that I want people to pay attention to because it is relevant. 94% of respondents in a 2014 survey of people in treatment for opioid addiction said they chose to use heroin because prescription opioids were far more expensive and harder to obtain.
Wow, that's interesting.
So we know of a lot of people who became addicted to opioids through sports medicine, sports injuries, car accidents, chronic back pain.
I have a question for you, and this is a common question that we got, and we actually got it earlier. Is it the car accident that gets the person addicted, or is the person likely going to be an addict no matter what? Is it the sports injury that gets the person addicted, or if we understand the addicted mind?
Well, it's our brain that gets us addicted.
Being the addicted mind being there prior to the drug, those people would have been addicted anyway.
Right.
I know lots of people that have sports injuries and go to the hospital and have surgeries, and they leave, and the first thing they want to do is be off their opiate.
Yeah.
But people that are addicts, they can't stop.
Right. And our brains are addictive brains naturally. And it's how we grow, that we gravitate towards things that are pleasurable. And as we age, many of us walk away from that obsessive obsessive nature and move on in life. And many of us can't get past that. I became an addict at 11 years old. I was dependent on marijuana at 11 years old. I was addicted to cocaine by the time I was 12 years old. I was addicted to smoking cigarettes when I was 8. And not because I wanted to, it's just the way things happen. And I wake up at the age of 25 and I'm in recovery and it's like, what the heck just happened? But I've been clean since then. Life is good. Life is precious and worth living. And I'm going to engage every addict that I possibly can to have the same experiences that I had in recovery and to be able to enjoy life once again. Because, addicts are passionate people. Yeah. Sensitive people.
Good. They're overly sensitive.
And
everything.
When they come into recovery, they're some of the most caring people I've ever met and some of the most genuine people I've ever met. I can't see myself doing anything different, and I don't think you can either, Ian.
Exactly.
So it's important to note that people are actually going to use heroin because it has become more and more difficult to get prescription medication. So it's an interesting fact, and it shows the impact of addiction, how powerful it is.
And we know now by the statistics in this year that there's an uprise of heroin. I know in BC they're seeing a lot of it. Mm-hmm. All over the United States they're seeing a lot of it. And they're even seeing heroin now in Manitoba.
Right.
Because people are having trouble getting their prescription.
Yeah. 20 years ago, the heroin mecca was Vancouver in Canada. That people would migrate to Vancouver to score and to try and pack and bring some back to Manitoba. I'm going to suggest that those folks didn't have much success because addicts they use it all, and they're not, and they don't like sharing so much, and they don't necessarily become the best dealers either. Right. So it's interesting. Whereas now in Winnipeg you can get heroin, and it's the same price, same purity levels as Vancouver, and it's scary. It's scary to think that my son's kids could access heroin in this city if they wanted to at some point. It's frightening. Teenagers, adolescents, 12 to 17 years old. In 2015, 276,000 adolescents were non-medical users of pain relievers, with 122,000 having an addiction to prescription pain relievers. It was only a couple of years ago I was working with teenage boys, 12, 13, 14-year-old boys who could score OxyContin by the line for $2.50. And it blew my mind to think that kids in this province can buy lines of OxyContin from a drug dealer for $2.50.
We hear that, the rates of opiate use in OxyContin on reserve, where people are poor, is out of control.
Yep. Yeah, they're a prime target.
Accessible.
Oftentimes throughout the year, people on reserves will have lumps of cash. And they're taken advantage of. and they're ripe for addiction. Isolated, have issues with lack of economy, lack of employment, generational issues, still the impact of residential schools, trauma, loss of culture, loss of language. It goes on and on and on. Yeah. And people have no problem taking advantage of that, which again, like I said, is frightening. Continuing with teenagers, the prescribing rates for prescription opioids among adolescents and young adults nearly doubled from 1994 to 2007. So it's not just addicts who are becoming addicts, or adults who are becoming addicts, folks, and it's not just adults who have access to pain medicine that maybe should be reconsidered, honestly. When I used morphine, that wasn't a drug that was typically prescribed for pain, except for the most serious pain and for cancer patients. And the truth is, most of our morphine came from people who had terminal diagnoses of cancer, and were more interested in putting some money in the bank for their kids than they were in taking the pain relievers themselves. So as an addict, we took full advantage of that. It was good business for us. And little did I know how much I'd be destroying my own life and the lives of people in my family and near me, you know, over the idea of chasing that dragon. Women.
Some questions.
Oh, okay. There are some questions coming in, so let's answer a few of them.
Absolutely.
Jerry, what was your recovery experience like? Was withdrawal difficult?
Well, when I went into recovery, the hot topic for addicts in recovery was methadone and whether or not people wanted to use a drug replacement therapy. I chose not to use methadone because I was in a paranoid state, and what I was told was, well, if you take methadone, Jerry, pharmacists will be able to track you across Canada. You're going to be in this system, this network, and people are going to know that you're an addict. And besides, you're just going to become addicted to methadone. So I chose to go cold turkey.
Methadone, isn't it more addicting than heroin?
I've known of addicts who have used heroin to withdraw from methadone. So it's very addictive. But the benefits of it are
some people can live, the small percentage of people that were long-term opiate addicts can live a normal life on methadone.
Right.
Very small percentage.
What it does is it helps a person get out of the lifestyle, the need to commit crime, the need to sell themselves. You know, the things that some people do for the sake of their drug. A drug replacement therapy like methadone or Suboxone actually help. But to get back to the question, was my recovery easy? No. Was I driven to be sober? Absolutely. I have never seen myself so desperate. I couldn't believe what my life had come to, but it was no easy kick. And I'll be honest with another piece that I tell people. For 2 years after I quit, I had needle dreams. I dreamt about using syringes, using drugs through syringes, and I would wake up in a cold sweat in the middle of the night. Those dreams haunted me, but I stuck to my plan. I had the support of fellow addicts who were there for me. When I needed a kick in the pants, I got a kick in the pants. When I needed a hug, I got a hug.
They were also asking about withdrawal, and it's very interesting. You know, when you got sober and when I got sober, a lot of withdrawal was just shake it out. Now we have lots of methods and a bunch of protocol around what we use to make somebody withdraw as comfortably as possible. And I don't want the whole hour to go away without us talking about that, about Suboxone and methadone and the difference. There were some questions that we got about that. But before we go on about the difficulties of withdrawals, one of our followers asked a question about methamphetamine and long-term recovery. And that feeling of happiness ever returning. Are requiring meth users, is there a requirement, or do you believe a belief that meth users should stay in treatment longer than 30 days?
Yes. And the reason I say that is it's known with chronic meth users that the brain damage, it takes up to 2 years for that to heal. 30 days, we're just starting to unfurl all the issues that an addict brings into treatment with them. Addicts are addicted to a drug. It's not the only dysfunction in their lives. We often find people are very lacking in coping skills. They're lacking in social skills. Those of us who became addicts as young people, we didn't get the opportunity to develop socially.
Even older. It was just pot and alcohol for me till I was about 24. So I was already older when I started using cocaine and methamphetamine. So I had some social skills,
Yeah.
but yet I'd never really learned any social skills because I was also always socially conscious or
Right.
socially anxious.
Does that mean that I want people to become institutionalized? No, but I did just shy of 24 months in residential treatment. There was a relapse in the middle, but I did 24 months. And at the same time, I watched a lot of people give up. I watched a lot of people walk away. I watched a lot of people go and relapse and die of overdose.
Yeah.
Um,
Well, we're also finding, I think, and we've actually experienced this at Aurora Recovery Center a lot, is that people on coming off of methamphetamine need 2 or 3 weeks to unwind before they're even program ready, where they can actually sit in a group
Right.
and participate in that group and stay in that group and stay seated and stay present.
Yeah.
Whereas before, there was a 72-hour quick detox, because that's really what it takes to get the stuff out of your system. But the emotional and all of the other symptoms take time now before people settle down.
Absolutely. It's evidence of the damage. We had a gentleman recently who was, for 2 weeks, was in a fog, couldn't communicate, couldn't sit still, was in clear psychosis. And it was disturbing to see it. But I'm glad the gentleman wasn't in a facility, that he was being looked after, that he was getting the medical attention that he needed, and that he was getting the support from fellow addicts.
Yeah.
Yep.
The member-centric idea that we've evolved into at Aurora is really important, because we want all of the people that come to Aurora to feel like part of the family and to feel like a member, like you're part of a membership versus a client or a patient.
What I appreciate about Aurora is the presence of the detox facility. I mean, from a medical perspective, the support that we as treatment counselors get from the detox staff, it's invaluable. You can't. I couldn't imagine doing treatment with people without having a detox on site. It's been so valuable. It's been so helpful. We're not having to drive people into the city. We're not having to book appointments at a clinic 2 weeks down the road. People are getting the medical attention they need right away. Nurse practitioners are fantastic. They're supportive of recovery. They're supportive of counselors.
That's why when we built Aurora, we really wanted to make sure that we had a full continuum of care, and detox is part of that, and such an incredible and important part of that. To continuum, to be able to come to Aurora 24/7, 365 in whatever condition you're in, and start your recovery process through a comfortable and healthy detox.
Absolutely. It doesn't get any better than that. And I've been doing this for a long time.
Another question, does the high price of legal depressants like alcohol and prescriptions drugs drive addicts to cheaper and harder drugs?
Yes. And that's been evident for many years. I mean, it's in terms of alcohol, people who drink mouthwash, people who drink certain types of wines that are meant for cooking that are, $2-3 a bottle. Yeah. And it's the same thing with drugs. There was just a stat that I read out about people moving to buying heroin because prescription medications are too expensive, or that they're being so regulated now, doctors are being so cautious that they can't get the prescriptions. Yeah. So they're going to heroin, which is kind of mind-boggling when you really think about it. Heroin does not have the fear factor that it had 30 years ago.
So a question that came in that we'll answer in essence of time. It says, I'm interested to know about the use of Suboxone for opiate addiction at Aurora.
Yep.
Is it the same as methadone? How long can it be used for? Is there evidence that shows that Suboxone reduces relapse as compared to abstinence programs?
Okay, there's
a few questions there.
Yeah.
So let's maybe discuss a few of those questions.
Suboxone and methadone are both synthetic opioids. Methadone is the older of the two.
Much easier to get off Suboxone than methadone. Methadone, to get off of it can take a year. Suboxone, you can get off of it in 3 weeks.
You can taper from an addiction onto Suboxone and off of Suboxone in a very short period of time compared to methadone. Both have advantages and both have disadvantages. Methadone is a better painkiller. And so what ends up happening when an opioid addict goes into recovery and starts to withdraw, their pain receptors come to life. And it's literally painful.
Yeah.
So methadone is better at helping the addict with that, and Suboxone less so.
But when we're doing detox of people, even from opiates, we wouldn't just use Suboxone as a detox agent, because we need to conquer some of that pain as well.
Right.
And once the Suboxone kicks in, it also combats some of the pain. Right?
So one of the advantages of methadone over Suboxone is you can literally be put on methadone the same day as a prescribing doctor or nurse practitioner is willing to, whereas Suboxone has to be a period of not using of 2 or 3 days.
Well, you have to be in active withdrawal.
Right. You have to be in active withdrawal. And so, but the stories are out there about methadone being much harder to withdraw from. The stories coming out of Vancouver are that people have used heroin to withdraw from methadone and then have used other substances to withdraw from heroin. So it's a nasty business. It's a really difficult piece to get. But if you stick with a plan, if you give of yourself to fellowship, if you can find trust in other people and fellow addicts, they'll help you get through that, right? Because that's really what it's about. It's about not being alone.
So the question is, yes, we use Suboxone for opiate addiction at Aurora.
We do.
We use it both as a detox agent and also as often an ORT or opioid replacement therapy.
Right.
So it's used in both cases. And what about the evidence that shows Suboxone reduces relapse?
There's tons of evidence, but I want to point out that there are abstinence programs that allow clients to use opioid replacement therapies. So, anyone who can get the help that works for them will have more success.
One more question about methadone and Suboxone. Methadone, actually, if taken too much, you get a physical effect from it.
You get high from it.
You get high from it.
It is an opioid.
Right, but Suboxone, that's not the case.
Suboxone is not the case. And the other thing that's important to know is that Suboxone contains naloxone. So if you attempt to abuse Suboxone, you will have a rather violent physical reaction to it. It'll make you very sick.
Using Suboxone.
Using Suboxone, injecting, and also trying to abuse other opioids while you're taking Suboxone.
So it has naloxone in it. So you're saying that the same stuff that saves people from dying is in Suboxone.
And it will make them very sick if they attempt to abuse it by injecting, or if they attempt to abuse other opioids at the same time.
So if someone's on Suboxone and uses an opiate,
they will get sick.
Okay, interesting.
So in that sense, it helps because methadone is being abused. Methadone is being sold, despite everyone's best efforts. It is being sold. There is a trade in it. And people, when they get their dosages up, are getting high and going on the nod with it. So those are the facts about Suboxone and methadone.
Okay. So as we're moving along here, one person asked a question, what can we do as a community and to combat the epidemic? I don't know if they mean community, meaning generalized overall community, Winnipeg, or are they talking about the recovery community or us at Aurora? But you can kind of look at all those questions.
I think the way to start in any setting is to start talking about it, to start being honest about it, to reach out to people who may have a problem with it and get them to understand that we're here to help them, that we can be trusted. Trust is a big issue with addicts and seeking recovery, and there's a lot of fear involved, and there's a lot of apprehension, and people are worried, and the idea of kicking a habit is not an easy one. You need
so
help.
The truth is, and someone asked, anyone could be abstinent if they put their mind to it.
Right.
And we're two people sitting here that are proof of that.
Right. Absolutely. It's not.
So even though there's these opiate replacement drugs that might combat someone from dying, ultimately those people could be sober, clean and sober and abstinent.
Absolutely.
If they work on themselves.
If they work on themselves and they give themselves a chance. And that's the critical part is, we're just starting to do some work that involves self-compassion. The addict's ability to look after himself or herself and the way they talk to themselves. It's such an important part of recovery that addicts are their own worst enemies. Everyone around them is trying to support them, trying to show them love. And in addiction, we tell ourselves the worst things. We have no faith in ourselves. We don't care for ourselves. We can't look in the mirror. And so we make it more difficult than anyone else does. So self-compassion is a really important part in recovery right now. How we talk to ourselves, how we treat ourselves. We don't forgive ourselves easily, and it's tragic.
So many people, another question someone just posed, I've been told to just get on methadone and you'll be fine.
Well, the truth is that methadone and Suboxone are to be prescribed in conjunction with counseling. That the expectation from the medical community is that it is being used as a withdrawal agent.
My experience has been that people that get on methadone, 90% of them start abusing another drug if they don't deal with the real problem, which is that thing that was inside of them as a kid, that gnawing at the brain, all of the stuff that goes on.
Right.
And that's been my experience, is that maybe for 10 or 20%, people can go on and manage their lives on an ORT.
I
But
would
the rest
suggest,
of-
that it's
The
a
rest
very
of the people
small percentage.
start abusing other drugs.
Well, absolutely. If they're not doing the work to withdraw, if they're not looking at cleaning up their lives, then why would they? Right? People need motivation, and sometimes it starts with external motivation. Sometimes it's a parent who's saying, "We've had enough." Sometimes it's an employer saying, "Hey, man, you got to get some help." And sometimes we just end up in a crack, and we have to do something about it. But methadone, Suboxone alone is not what I would recommend. I'd recommend that in conjunction with counseling.
And ultimate tapers.
And ultimately, tapering. There's no need to stay on it long term. Your brain will heal. You will feel better. You will see value in life again. Sobriety will strike you as being rather pleasant and worth having.
So one of the questions is the medical community finds it really important to keep people on Suboxone or methadone because the chance of death in relapse is so high with opiate addicts. So it's a medical need. The need for someone to remain on an ORT or an opiate replacement therapy, ultimately from this comment that's being made, is ultimately because of the potential of death
Absolutely.
in opiate
And so,
addicts.
I was talking to one of our nurse practitioners at Aurora today about that very issue, right? And the evidence-based best practice is that a minimum of 1 year for Suboxone or methadone to help that person get through that initial first year of recovery, to get through the rough spots, to avoid the idea of relapse, because we now know that with both alcohol and other drugs, the more often people relapse, the more damage they do. And I know for a fact that someone who's in recovery for a period of time and has a relapse is going to heap tons of shame onto themselves, tons of guilt onto themselves, and they're going to hit their drug of choice even harder the next time around, which makes recovery withdrawal that much more difficult every time. Yep. It's a serious business. But I don't want to scare people off with that either. I'm about encouraging people to look for ways to enjoy life, look for ways to repair relationships, look for ways to bring love back into your life.
Just a quick reminder as we get close to the 15-minute mark before we close this webinar, please submit questions. We really are appreciating the questions that you're submitting to this point, and we would really appreciate you to submit some more questions. Another question that came in was for you, Jerry, is how does meth affect men differently than women?
Well, that's a good question. Do you have an answer for that, Ian?
You want me to answer?
Yeah,
Well, I think actually it's very similar. But what we're finding is the exploitation of women on methamphetamine is very high. You were talking about earlier about young girls and young women getting addicted to methamphetamine, and it's because of the high sexual appetite. And the high sexual appetite, very often women end up soliciting themselves on the streets and/or with pimps. And interestingly enough, the research shows now that maybe 60% of men also solicit themselves at a young age because of the use of methamphetamine.
Yeah.
But it's very different, obviously, and the psychosis is very different in men than women. Men tend to get introverted and violent, and women tend to cut or pick or destroy their bodies or their skin because of the use of methamphetamine.
Yeah. The effect on the brain is the same for both sexes. It's how the sexes act out pain. It's how they act out their disdain for themselves, right? But we see all of it, and it can be frightening.
Yeah, I mean, I know that methamphetamine turned me to the sex trade for a while, and I was a guy going through medical school, optometry school at the time, and it pushed me that way just because of the high sexual appetite and the desire to do dangerous things,
right,
and things that were wrong.
Right. And I mean, people are even using it for raving, and also what's happening on our streets in this very city is that people are buying what they think is crack cocaine and in fact is crystal meth, or vice versa, that people think they're buying crystal meth and they're getting crack cocaine.
So that brings us to another question. There was a question about we understand today that often fentanyl is being laced, every other drug, marijuana, crystal meth, cocaine, is being actually laced with fentanyl.
Right. Even heroin is being laced with fentanyl. And it's the same with fentanyl. People are buying what they think is fentanyl. They're getting heroin.
Because it's so cheap.
And people are buying what they think is heroin when in fact it's fentanyl.
Yeah, and carfentanil because it's so cheap.
Carfentanil, and people at this point in time are taking a big risk in buying any kind of powdered drug. They have really no idea what they're buying.
Yeah.
And dealers don't care.
Yeah. Cocaine they put methamphetamine in cocaine for a long time to make it stronger.
They put procaine in cocaine. There's all kinds of cutting agents that dealers use. Folks, dealers don't care about you. That's the bottom line here.
Do you feel that the question here is, do you feel that that those on methadone and Suboxone therapy plans Ian, do you feel that on these methadone and Suboxone therapy plans, people are able to address a 12-step program the same as someone that's not on a therapy plan? That's a really good question. And I really, at one point in time in Winnipeg, they started a group for people that were on opiate replacement therapies that wanted to do the 12 steps and remain clean and sober on other stuff. And from my experience, and this is just my experience, there's really no issues around being on Suboxone and working the 12-step program. But I have seen lots of cases of people on methadone where their dose is too high, where they're drowsy, where they're really using it as a drug still, where they've had a really hard time in abstinence-based 12-step programs.
I just had a very young man graduate from Aurora who's on my caseload who was on Suboxone, and it wasn't impacting his program. It wasn't impacting his participation. No one viewed him differently. And I'm currently working with a young man who is on Suboxone, who's shaking a little rough right now because he's in recovery, and but everything is fine. Everything's on point. Everything's moving forward. It's, the old school, more conservative type addiction providers tend to want to weigh in on people using ORTs, opioid replacement therapies, as that they're still high and they're not actually in recovery. And I disagree. It's medically prescribed. It's a medical intervention. It's the safest process for somebody who's withdrawing. And I don't see a need to pass judgment on anyone who's using an opioid replacement.
I would agree with you. But the reference I was making is there's a big difference between someone drowsy sitting on the couch every day at a 12-step meeting on methadone and a Suboxone user that really can see no effect whatsoever physically in that person. Right. Someone else asked, how about being pregnant and using methamphetamine? Then they said it's a bar idea. Great idea. Any statistics or info on or experience with this?
I don't have any stats on that. The experience and the information that's out there currently, and they're doing some research, would suggest that the impact on the fetus is the same as someone who's abusing crack cocaine. And I just want to relate the idea that crack cocaine, the recovery period on the brain is about 6 months, whereas with crystal meth, it's up to 2 years. Yeah. So that tells me that the impact
on an fetus brain is going to be significant. I also think that, as we know, one of the most disturbing things I ever had to see in my life was a woman that was an opiate addict that gave birth to a baby. And I had to go see her at the hospital and see the baby. And the baby was being treated with methadone because the baby was high when it was born. And they were so worried about the withdrawal in the baby because the baby could die. Right. And I would suggest it's the same with methamphetamine.
Yeah,
there'd be horrible effects at birth. Yeah. You're creating without a choice a child that is addicted at birth.
Right. Yeah. And I mean, as we know, women become pregnant, don't realize they're pregnant, and continue a lifestyle. I'm going to suggest that women want to protect their babies, that they want to have the best pregnancies they can, but you don't automatically become aware that you're pregnant. That sometimes there's some weeks before you figure it out, then it's too late.
Yeah.
Right. So it's a sad situation.
So if you're pregnant and having trouble with any drugs, it's really important to get treatment or help.
Reach out for help.
Stay off of those drugs while you're pregnant.
There are people who want to help in a non-judgmental way, in a kind way, in a gentle way. So reach out.
Should I question that just came in? Should I get on methadone till I get into a recovery program?
If you believe it will help you get out of the lifestyle, if you believe it will reduce the harm to yourself and to others, absolutely. But please don't do one without the other.
All right. some more stats or some more information. Once again, we're about 10 minutes away from closing this webinar on opiates or opioids and methamphetamine. We've enjoyed the questions so far and enjoyed your interaction. Please feel free still to send us any questions, and we'll be glad to answer them.
So we're gonna put a graphic up here that it's Canadian stats, which I like because I think it's relevant. Issued by the Department of Health, Government of Canada, and this applies to the year 2016. And you can see the number of deaths per 100,000 in the population of Canada. You can obviously see opiates from opioids.
That's what we know about.
That's what we know about.
There's hundreds more that we don't know about.
You can see there's a bit of a trend that moves from the most severe areas being the West Coast, but now, like I said, 30 years ago, the idea of heroin in Winnipeg, the only way that was happening is if an addict brought back a couple of packs. Otherwise, now we're seeing a sweep of opioid-related deaths right across the prairies, up into the north, coming down into southern Ontario, and going out into the East Coast. So it's not, BC and Alberta are still heavily impacted by it, but it's moving across the country, folks. This is not just about Vancouver anymore. It's not just about Calgary anymore. It's about Regina. It's about Yorkton. It's about Winnipeg. It's about Brandon. It's about Hamilton. It's about Sudbury.
Toronto and Ottawa.
Toronto, Moncton. It's out there. People are dying. And I'm going to believe that most of it is, in fact, accidental. All right, that people are wanting to use these drugs, not realizing the impact, using too much of it, or using drugs that are, in fact, not the drug that they think it is, something laced with fentanyl.
Here's another question from a mother. My son overdosed 3 days ago, and they brought him back to life. And then he promised me that he thought that he would never do it again based on that experience. And last night I was at the hospital with him again from another. I found him in his bed, overdosed, and I had to do CPR with my husband until we got the paramedics there, and he overdosed again and ended up in the hospital.
Well,
So I think it's really important to talk about the obsession, right? To use more. Everybody might be well-meaning that they're not going to use again. I'm never going to do that. I learned my lesson. I mean, I had 7 arrests before I learned my lesson. 7. Even though the first time I thought, I better not do this anymore. I'm going to end up in jail with these guys for a long time. And United States jails, Cook County Jail was not a pretty place. And I thought, I better never do this again. And then 6 more arrests after that. So
first of all, I'm sorry to hear that. That's got to be something really difficult to deal with. I can't imagine what you're going through. It speaks to the power of addiction. It speaks to the power of the human brain when the human brain is addicted and what it's willing to do, what it's willing to seek out, what it wants. And what it wants is more. There's just no other way to say it other than the brain wants more.
Yeah.
The idea of overdosing doesn't scare addicts all that much. It's just part of the game. It's part of the process. It happens. You get some help and you get back on your feet and you go find your next fix because you're still addicted. They'll treat you in a hospital.
Yeah.
But you will be released. And unless someone gets help, that person's going to go back out and chase the dragon again.
All right. There's one more question. I can't afford recovery right now. What should I do till I get in? So obviously it's someone that might be waiting in the public system. At Aurora Recovery Center, we have no wait times. We built the building so that we never have to say no to anybody. You can come in, like I said earlier, 24/7, 365. Of course, we're a private facility, but we have access. You have access to the facility very quickly. So what can people do till they get into to treatment?
Well, there are detox facilities in the city that you can access. And I always encourage people to look to detox before entering recovery. First of all, you're going to be safe. Second of all, you're going to get the medical help you need in a detox facility. It's a medical issue, folks. Let's deal with it accordingly. There are professionals in the system who their sole purpose is to get you through the night, is to keep you alive until you can get into a bed where you're going to get the help that you need. So seek that out. Call us. We'll make some time for you prior to entering the program. If there are financial issues, call us, talk to us about it.
Figure it out for you.
We'll figure it out. We're here to help. It's offering good treatment is not cheap, folks.
Yeah.
The wealth of experience, the qualified staff, the therapists we have on staff, the detox facility with nurse practitioners, psychiatric nurses, registered nurses. Good quality care doesn't come cheap.
Well, we also, just quickly, when we're talking about that, we also have our counseling here in Winnipeg on Scurfield Road, where you can access some other programs, some one-on-one counseling at any time. So if you can't afford it and you're having a real hard time, you can also contact our counseling on Scurfield and maybe meet with one of our therapists or counselors at ARC 1 or 2 times before you can get into some kind of treatment program. In saying that, also just quickly, because we're coming close to the end of the hour, believe it or not, that went really quick today. Tomorrow we're going to have our last webinar. We're going to be talking about interventions and how families can intervene on loved ones that are struggling with addiction. So please join us again tomorrow night at 7 o'clock for the last and 5th of our webinar series on interventions. If you want to get help at our counseling, you can call 844-515-7867. That's 844-515-7867. Or of course, you can go to aurorarecoverycenter.com and submit an information sheet, which we'll get to them as well. Any other last minute points? We have about 3 minutes left, Jerry.
I just want to show this one graph that relates to the sex distribution of apparent opioid related deaths. It's interesting because it's not just a disease that affects men. It affects everybody. So here's a graph, shows you some stats. Again, they're Canadian stats. This is coming from the Government of Canada, the Department of Health. These are valid stats. They're current 2016. You can see across the country the percentage of opioid-related deaths, with the lighter colored blue being representing women and the darker blue representing men. So, look at Manitoba, look at Saskatchewan, which have very similar stats. 42% of the deaths are women. It's not just men who are overdosing on opioids, folks. It's women as well. Newfoundland and Labrador. Who'd have thought Newfoundland and Labrador? Over to British Columbia, it would appear that it's predominantly men who are overdosing on opioids and dying as a result. But it's not. The purpose of this graph is to show that it's not just men. Women are just as much at risk as men are.
So thanks again for joining us tonight on our discussion about opiates and methamphetamine. We could sit here for hours and talk about it. It seems like I really appreciate all the questions and the input from everybody on the webinar community. And just remember, tomorrow night we're back again from 7 to 8 to talk about interventions, and we'll look forward to seeing you again. Thanks and have a great night.
Thanks, folks.